very closely with our pharmacy staff, including the amazing Melanie Chan. So I'll let her introduce herself as well.
My name is Melanie Chan. I'm the Pharmacy Assistant Director here at Stanford Children's. One of my passions and projects that I've always been working on is anything related to patient safety, and this includes what we're going to be presenting.
Stanford Children's Health of being focused on medication safety in particular, especially as it relates to the unique issues that come up with pediatric care. We looked specifically at medication error prevention in children's hospitals as far back as the 1980s. This is an article that was written by our then head of pharmacy as well as our pharmacy and therapeutics chair. Since that time, we have taken a very multidisciplinary approach to trying to constantly improve our medication safety. In the late 2000s and around the turn of the decade, the California Department of Public Health started mandating that hospitals in California come up with a comprehensive medication error reduction plan. This was something that was very easy for us to do because we'd already been trying to systematically address these issues. The way our medication error reduction plan works is there are 11 different areas around medication prescribing and administration that we evaluate every year. We come up with a specific plan for each of those areas for how we will improve safety around each element, and then at the end of the year evaluate the impact of our interventions and design enhancements or new interventions for the following year. Again, disciplinary process, so as you've heard from the beginning, Mel and I have worked very closely together. We work with a team of both physicians, nurses, pharmacists, our information services analysts, as well as the many other medical staff like respiratory therapists or ancillary services that help us with medication safety. Our team came up with a list of principles that would guide our interventions on medication safety, and this is what we use to help us in designing and implementing our medication safety plan every year. I'd just like to highlight that one of those principles is technology implementation shall be part of the plan. We realized early on that technology has the potential to hardwire many of these interventions so that we get the sustainable effects that we want to see. So to four particular interventions that we have done over the last several years that are designed specifically to enhance medication safety and truly address some of the specific pediatric issues that we face. So the first one is medication cart fill optimization. The second is our management system for sterile compounding. The third is our management system for non-sterile compounding. And then finally, barcode medication administration, again with a focus on some of the unique things that we implemented in our organization around barcode med administration. And at the right, you can see the four key drivers that really help guide these implementations or these interventions. Mel to talk about the first intervention.
Thank you. The first intervention I'm going to talk about is medication cart fill optimization. And the problem we have with the existing cart fill system was that medications were essentially processed 36 to 24 hours prior to when the dose was due. So what happens is that then this results in a lot of medications for the nurse. It's 24-hour supply. And there's, as you can see in the photo, that's an actual photo of a 24-hour supply for a cardiac patient. So for the nurse to find the correct medication at the right time becomes rather challenging. So to look at some of the vulnerabilities. And what we discovered was that discontinued medications that were remaining in patient's bin contributed to wrong dose, wrong medication, wrong route. There were delays related to missing doses and dispensing orders errors. Doses were discontinued, orders were modified, patient discharged, and lost doses. There was also time loss on the side of nursing looking for medication, and for pharmacy when we had to do a lot of rework for some of the lost doses. So we optimized this while optimizing patient safety, increasing quality of care, and also increasing efficiency. So our driving principle was really to utilize the lean principles. And what we did was to look at the frequency and times for the cart fill. How could we reduce waste from discontinue, missing, or change doses? And also to reduce waste from production and cart fill, and to look for opportunities of improvement for workflow. It was multidisciplinary. It was headed by pharmacy leadership. We involved patient safety, Safe Medication Practice Committee, which is a interdisciplinary committee with nursing, pharmacy, respiratory therapists, anesthesiologists. We created multiple cart fill task force, and we also included information services, other staff from pharmacy and nursing. The task force, pharmacy task force, was composed of pharmacists and pharmacy technicians looked at the problem. We did a lot of simulations in terms of pharmacy workflow. We solicited nursing input, and we took this to the Safe Medication Practice Work Group to look at the process as a whole. We looked at doses administered per hour to look at how we could best level workflow. Data pieces that we looked at was really the number of doses per hour, because this really kind of helped to determine how many times we needed to have our cart fills and delivery so that the nurses would have the medications when they needed. So here you can see we have oral daily doses by hour, and we also looked at the IV doses by hour. And as you can see, for the daily doses, we had peaks because of the once a day and twice a day dosing. As an aggregate, and from this 3 pieces of data, we came up with a draft of what the new cart fill times would look like. So we went from a 24-hour cart fill to potentially every 2 hours, as you can see here, which I believe we started out with 10. And we highlighted here 2 of them, which is the 8 a.m. and 8 p.m., which is a larger fill, because of the volume of doses that are due at that time. So in order to design this, we had to work very closely with our IS team to determine when the labels would print and the report would come to pharmacy. We had to account for production time in the pharmacy and technician delivery, and to give the nurses enough time to prepare the doses to administer to the patient. Our IS analysts on the build, and what we were able to do, they were able to further identify additional concerns that we had to build into our workflow. So it was a very close working relationship with operations and the IS analysts. So some of the things that were identified at this point was what would we do on the weekends, what would we do when a certain satellite was closed. So we were able to troubleshoot and come up with a plan before the go live. Now, instead of 36 hours prior to a dose being due, 5 to 7 hours prior to the dose, and in every 2-hour blocks, the AHR generates a fill report and labels. Doses are prepared by the pharmacy, both IV and oral doses. Doses are checked by the pharmacist, delivered by the technician, and we also implemented a system in which the nurse has a 2-hour supply, the next 2-hour supply medication, and another 2-hour supply, so a total of 4, but it's separated. This allows the nurse, if she needs to either do some rescheduling or to do some advanced preparation. the nurse is now easily able to select the correct medication and then administer the medication. On the right-hand side, you see a typical cardiology bin on a 24-hour supply, and on the bottom right, you see a typical cardiology bin on the 2-hour fill. So as you can see, it's much easier for the nurse to find the needed medication. This is that there was a lot of workload leveling. So as you can see here, we looked at pre and post prepared doses per hour. And the light blue and dark blue is pre. And you can see here we have some pretty big spikes. And then for the post, you can see for the most part, there's much more work leveling. So this allows us to be more effective in the pharmacy and efficient. Also looked at missing doses. Prior to implementation, in a month, there was about over 2,000 missing doses reported. Post-implementation, about 3 months post-implementation, we looked at the same, and we actually had a decrease of roughly 20% decrease in missing doses. The value from this particular project was waste reduction. We collected the waste when we were in a 24-hour cart fill system, and then we did the same for about a week time period when we were on the 2-hour cart fill system. As you can see here, there was about 66% reduction in total doses wasted. In a 12-month average, we looked at the number of monthly doses dispensed, and that is pretty much a reflection of doses that are saved, that are not wasted, because we're no longer dispensing doses that are thrown out because the patients are discharged, because the orders are being modified. So when we looked at the pre-12 pharmacy was dispensing roughly 190,000 doses per month, and immediately, you can see here with the red line there, it dropped about 30%. And that 30% decrease has actually, our 130 doses has been pretty consistent to the current state. We do see a little bit of a gap there because we did change our EHR system, so I did lose a little bit of data. But looking at recent data, we have maintained that number of monthly doses dispensed. As a note, our case mix index has not changed. If anything, it's probably increased, and our general census has actually been increased. So it's 60,000 doses per month and using $1 per dose, and we all know that drugs are not $1 per dose. This results in an annual cost saving of over $700,000. We looked at respiratory medications and changing that. We made some adjustments to the cart fill times due to workflow and nursing workflow. And we also had expansion to include oncology center. And when we move into our new hospital expansion, we'll be including those new areas also. Just as a note, when we included our BASS Center in 2013, post-implementation showed a 79% waste reduction in that particular unit. Talk about is our sterile compounding management system, and this is for our intravenous medications. Pediatrics, so we have some pretty unique challenges in the pediatric population. Doses have to be very specific. They're patient-specific doses due to weight base. And also, there's a lot of manipulation on part of pharmacy because our philosophy here is that doses should be dispensed ready to administer to the nurse. And this will allow the nurse to spend more time at the bedside. Also, we have a lot of regulatory compliance issues, both with the Board of Pharmacy, Joint Commission, CMS, and also with the Drug Chain Supply Security Act. What you see in our previous system in which dilutions, which is very commonly used in pediatrics, were made on these little cards here, and you can see there's no reference, it's not signed off, and everything was paper log. So it took a lot of time for our pharmacists and technicians to do a paper log. And of course, there's always the risk of transcription errors, and we had to find something, we had to go through quite a bit of paper. One of the reasons why we embarked on this journey was because several years ago there was an error, and this particular error occurred when we had a medication that we were not as familiar with, did not use very frequently, and a dilution was needed because it was for a neonatal patient in the ICU. And so the pharmacist processed the order, had the label, ran into the IV room, gave it to the technician, and said, "This is stat." The technician, being pressured, did not read the label carefully, did not realize it was a dilution, and the pharmacist, because it was stat and there was a lot of pressure from the ICU, checked it and did not realize it was a dilution. So it was dispensed and administered, and the patient had some pretty significant acid-base dysfunction as a result. So as part of the RCA for this particular issue, we looked at, okay, how can we make the system safer for our patients? We looked at different IV workflow managers, and what we were really looking for is how can it help us decrease medication errors, enhance productivity, reduce waste, and improve regulatory compliance, and most importantly, interface with our existing EHR so that we would not have to transcribe, and it would interface and flow from the EHR to the system. We were pretty much an early adopter. At the time, there were not a lot of vendors available with this particular technology. So, governance structure, which is very similar to the previous one, pharmacy leadership led the project. And again, because this was a safety issue, we involved our patient safety, and because this is a big project that required integration with our EHR system, involved the IS Strat Planning Committee. We created a dosage implementation task force, which included information services, a pharmacy project team, and design and construction, because it did involve some remodeling of the pharmacy. This is called dosage, and where it impacts in the process in pharmacy is the technician preparation and the pharmacist verification. It is interfaced with the EHR. It is patient-specific. The orders flow to a queue for the pharmacy technician. So now they are able to prioritize in terms of urgency and type, and that's something they were not able to do previously when they had a stack of labels. When they had to do product selection, every product they choose is barcode validated. So, for example, in the previous example of the error, if the technician pulled the vial that was not diluted, the system would say, hey, this is not diluted, you need to dilute it, and this is what you're going to do. If they pulled the medication that was incorrect, the system would not let them move forward and tell the pharmacy technician that this was a wrong product. During the preparation process, there's detailed preparation instructions, image capture of each of the steps, and a final image capture of the final product. And this is what the pharmacist looks at when they are checking the product. So they are now able to do remote verification. So in the ICU, if the pharmacist is verifying this order on the unit, next to this very sick patient, they're able to help the process and move it along because they can actually see and verify this anywhere they have access. There is photo verification, and also is barcode enabled, which allows the nurse to scan the label and to complete the barcode medication administration process. All of these steps are archived in the dosage system, so at any time we can go back and review the process. So our implementation was, we started in 2011 as a pilot project. expanded to our main pharmacy areas in 12, oncology satellite in 13. We have a major upgrade in 15, and with the new hospital expansion, in a few months, we'll be expanding it to those areas. What we looked at is potential errors averted during production. And so most commonly, as you see here, is incorrect drug. And you do see here been pretty consistent. We do have a little spike in 2016, which we're not sure why. We've been investigating that. I do want to mention very briefly that ISMP does have a study that shows that majority of the errors in pharmacy is during the IV compounding process. So with this new system, we're able to catch these errors before they even go to the pharmacist for checking. But the system has also increased capacity with no changes in resources. So what you see here is the number of IV doses that the pharmacy has prepared on a monthly basis, and the technician hours really have stayed consistent throughout the whole time. Reduction, and the waste reduction is because when a dose is discontinued in the system by a physician and verified by the pharmacist, it falls off the queue. So it's never made and discarded by the pharmacy. Because of this, we now have approximately almost 7,000 doses that were averted. In addition, errors that were prevented, and if we do an average cost of $15 per dose, it's $150,000 that was saved during this time period. We would anticipate more doses being saved. However, at the same time, we also had a multiple cart fill, and that also decreased waste. So this is in addition to the cart fill system cost savings. So improvements of data analysis, we look at how we can make it better. We look at why we have wrong product scanning, and we find that a lot of it's look-alike, sound-alike medications. And so we look at, can we, have products that look more differently, how we can label it so that we have less of that risk. We've been able to add special instructions, especially related to special filters, special compounding instructions, and new medication formulations are added, and also is a workflow management across areas and optimizing this particular system. System I'm going to talk about is our non-sterile compounding management system, and this is for our oral medications.
Which gets to be a big issue for pediatrics specifically.
Yes. And again, we have very similar issues in pediatrics that we do with the IV medications, because most of the medication, kids cannot take the tablet, or the dose is not appropriate for pediatrics. So there are very limited oral suspensions and solutions out there for our pediatric patients. So pharmacies need to make these particular oral suspensions. Because of this, we wanted to be able to link the source ingredient to the final dose. So if I have a patient that needs an aldactoside dose, that's like 1.5 milligrams, pharmacy needs to make an aldactoside suspension, and they make a big bottle of this, and from that bottle, we have multiple doses going to several patients. So how do I link that tablet and those ingredients from that particular suspension all the way to the dose that's being administered? So we had a very manual system, and we had basically what we call a master formula that was typed up on paper, which eventually we transitioned to a standalone third-party vendor. And when we had paper, you can see here our very big box of records. The problem with the third-party vendor, it was a standalone system and did not integrate with our EHR. So it was a standalone system. The other problem with this particular is that the labels that would come up for the oral medications, we were unable to prioritize or sort. And so at any one time during a cart fill, a technician can get a couple hundred labels, and then at the same time we have first dose labels coming out. And so the pharmacist would tell the technician, hey, I have something that needs to go out, and the technician would have to scan through all those labels looking for that particular dose. So we had missing doses, it was a manual checking system, and there was delay in stat or first doses being dispensed. What we wanted to do with this particular project is to look at how can we decrease medication errors, streamline the workflow, and really to improve documentation and tracking. There really wasn't a lot of vendors available with this technology. We've been looking for a few years, and there was nothing that was satisfactory that would meet our needs and also improve our workflow. So when we decided to go with our new EHR vendor, there was some functionality in the system that we thought we might be able to adapt to meet our needs. So to further evaluate it and to hopefully implement this, we created a non-sterile compounding governance, which pharmacy leadership helped to manage this. And we involved patient safety, clinical oversight committee, which helped to oversee our whole EHR conversion at the time. And we had a non-sterile compounding work group, and we involved the IS services, pharmacy, and nursing. It was a little bit unique in the sense that the system was not intended to be used for oral medications. So our planning is what we had to do first is really to say, what is it we want out of the system? So we set our goals, and we tried to clean up our sterile compounding recipes and standardize it. Then the next part was an interesting part. We had to work very closely with our IS colleagues to say, this is the existing technology that we have in the EHR, or that was going to be implemented. This is our needs. How can we get to this point? So what we looked at, there was a lot of simulation, a lot of testing. We had multiple rounds of testing and build. And then eventually we had a system we felt that was satisfactory. We trained our super users. We had a lot of communication. And then we had a go live. And once we had a go live, there's a live feedback. And we used analytics to look at, is it meeting our needs? And is it working? That this particular strategy impacted was really the dispensing of the medication and the preparation in the pharmacy, as you see here. So what we were able to integrate is something called the dispense queue, dispense prep, dispense check, and dispense tracking. Derived. So what we're able to do now is in my aldacticide example, when we do an aldacticide suspension, the recipes are all built into the system, and with every recipe that we compound for the bulk compounding, all the medications are barcode verified. So the technician will scan the tablet, scan the simple syrup and any other ingredient that's needed for the compounded, and this validates it's the right ingredient. It puts in the NDC, the lot number, if it's available in the barcode, otherwise it's manually added. And there's also electronic signature and event capture of all of these steps. Analytics, we can also pull analytics from this to look at what medications are we making, are we not making, and so we can sunset medications that are no longer being used. So important, this is something that we really were driving for, and so we looked at compliance with dispense prep, and what, in the example of the aldacticide, once I have that suspension, that label now has a barcode. So the technician prints the label, They scan the bottle and they scan the label, and it will tell the technician if they have the right medication or not. As you can see here, we have an over 95% compliance in both 2015 and 2016. And we did have some warnings in which the barcode was not recognized, and primarily this was due to vendor changing their NDC, and so we were able to upgrade it in the system using the data provided. And for wrong medication scan, we also looked at why it was this case. To look-alike, sound-alike medication. So it shows you in terms of, this is just a little picture of what the suspension looks like when the technician and the required elements. So there's now electronic signature, is tracked from the compounder to dispensing to an administration in the electronic health record. And we also now comply with the Drugs Chain Security Act, in which we now can track a medication from when we receive it in the pharmacy to when it's administered to the patient. Ongoing in improvement is with the data. We can see where our workflow is, so we can reallocate resources. We can look at shift time updates if we need to. We can also help to design error prevention strategies because we know where the errors are happening. All new medications and formulations are also added into the system.
Great. So I'm going to take over for the last intervention, which is barcode med administration, and we'll do this one fairly quickly because by now most people know the benefits of barcode med administration. What I'm going to focus on are a few of the unique aspects of how we implemented it, as well as tying it to some of the great work that Mel's been talking about. So again, there's a huge issue with, we know that a lot of our medication safety issues come from administration, and barcode med administration is designed to address these issues. So our intended outcomes, of course, to decrease medication errors, but really one of the things we were focusing on was facilitating immediate compliance with barcode med administration at the time of our EHR conversion. We had talked with several other hospitals who had recently done an implementation and learned from some of the issues that they had with getting compliance, getting people accustomed to the new system, and that's what we really were trying to address so that we could have a smooth implementation. So, as I mentioned, came in as part of our EHR conversion, and so came under the governance of our overall EHR implementation oversight group, multiple different disciplines and task force involved in this complex project. We have an implementation strategy that is, for the most part, fairly consistent with other folks' implementation strategy for BCMA. The one piece that I would highlight is under that build section is we incorporated high-fidelity simulation, testing, and training, and I'll talk a little bit more about that in a minute. Our workflow is fairly standard. I won't go through this slide in detail because, again, this is something that thankfully is becoming more and more standard across hospitals. But again, unique piece that we used. So because we had learned from other hospitals about some of the challenges that came up when implementing barcode med administration, we really wanted to test it thoroughly in an environment that was as close to our clinical environment as possible. So we used our high-fidelity simulation centers to go through the entire workflow associated with barcode med administration and incorporated our bedside staff in both the testing and the training in the high-fidelity sim center so that we could identify and address any issues. So, for example, when we were testing on our teeny-tiny infant models, we identified with issues with the barcode being too small on the wristband and trying to reformat how those labels looked. Went through all of those workflows, tested them, addressed the issues, and then also used that to help train our nurses so that at the time of go live, they were equipped to adapt to this new process. And what we saw was very high immediate compliance with barcode med administration right after our EHR go live. Within the first week, we were above 90% compliance, which we were very excited about. The huge advantage is increased safety, and we're able to track the number of near misses that our barcode med administration has prevented. But again, what I want to highlight is how barcode med administration, in conjunction with all of the other systems that Mel has just talked about, has really created an increased safety net across the entire process of medication ordering to preparation to administration. So, for example, when the FDA recently announced that there was an issue with contaminated DocuState with Burkholderia, we were immediately able to use both our system for non-sterile compounding in conjunction with our barcode med administration system to identify which vials had been contaminated and connect those immediately with the patients who were at the end of that administration. This in the past would have been going through tons of paperwork and would have been almost impossible, if not very challenging, to locate, and this is essentially a push of a button for us to identify these patients. So we are continuing to work on improvements in our barcode med administration. We are extending into our ambulatory settings and working on implementing our nursing smartphone platform so that they have an integrated barcode scanner with them at all times. But so far, it's been a very successful intervention. So finally, just taking a look at the combined effect of all four of these interventions, this is a graph of our incident reporting of medication errors during the times of these interventions. And you can see some of the times when we implemented these. Again, no is not a perfect way, is far from a perfect way to capture all errors, but it is one of the best ways that we have right now. And you can see over the time of these interventions, we saw a steady decrease in the medication errors that we reported. This graph, unfortunately, ends in November of 15 because that was the point when we implemented a new incident reporting system, which was designed to be easier. But initially, we saw a dramatic decrease in our error reporting as people got accustomed to the new system. So it's a little hard to compare before and after. But if you take a look at our overall graph, and this is provided by the Solutions for Patient Safety, which is a national collaborative of children's hospitals. And if you look at our incident reporting, which is the red solid line, very low to the bottom, our medication errors, again, according to incident reporting, have continued to be incredibly low compared to the rest of the collaborative. And we really attribute this to the ongoing patient safety work and the ongoing collaboration between all of the multiple disciplines in our hospital. Continuing to look for new ways to improve medication safety and know that there is a lot of work still to be done. We will be continuing to implement multiple different interventions in the next few years, and we're excited to continue to make medication an even safer process for our patients. For listening to us. It's really been our pleasure to share this work with you.
To Melanie and Natalie, thank you for that great presentation, and thank you for joining us for this Davies webinar, and more Davies use case webinars and information on how to apply for the Davies Award can be found at the HIMSS Davies Award website at hims.org/Davies. And thank you, that was great. That was perfect.